So the RESONATE trial is the first randomised phase 3 trial of ibrutinib in CLL that we'll report for the first time in the EHA meeting here. We're taking patients, or patients were included in the trial who had relapsed refractory CLL, so were really unsuitable for conventional chemotherapy-based treatments, either because they were too unwell to have such treatments, or the disease was resistant to or would have been resistant to therapy. The patients were 391 patients were randomised, so it's a very large trial for this group of patients, between a standard treatment of ofatumumab, which is approved for patients in this group with this type of disease, or versus ibrutinib. Initially, the patients were not permitted to cross over between the two arms, but during the follow-up of the trial, the Data Monitoring Committee indicated they wanted patients to be able to cross over because of the emerging results they were seeing. So the patients were randomised. The primary endpoint of the trial was progression-free survival, as we usually use in CLL. What we'll present at the meeting tomorrow is that there's a very big difference between the two arms, with ibrutinib having a highly significant advantage in terms of progression-free survival. In the trial, almost every patient in the ofatumumab arm had progressed at 12 months from randomisation, whereas over half of the patients, or significantly over half of the patients, were progression-free at that point on ibrutinib, with the majority of patients remaining on treatment and doing very well. What's really impressive about the data is, despite the crossover, and many patients crossed over from ofatumumab to ibrutinib, there was an overall survival advantage in favour of the ibrutinib arm. So the patients in ibrutinib were having a significantly better chance of remaining alive, and when the patients crossed over, the ofatumumab patients benefited from the treatment with ibrutinib. This trial shows that single-agent ibrutinib therapy is the most effective therapy for patients with relapsed refractory disease that we've seen in randomised trials. I'm sure that it will be, it's not yet approved in Europe, but will be approved in the coming months in Europe, I'm sure, as a single agent in CLL, and that will have a major impact for patients with poor risk disease. I think the excitement is as well as having such an effective therapy, is how we combine this therapy with other agents, both our conventional chemoimmunotherapy agents, but also antibody agents, so chemotherapy-free regimes, and with the advent of other targeted therapies, how we combine the targeted therapies together to improve remissions and improve outcomes for all patients with CLL.